Hi, I'm Dr. Mehboob, MD Ophthalmology from AIMS New Delhi, and I have come with this part 3 of the Rapid Revision NEET PG series, where I am discussing the 100 MCQ in 4 parts and covering the whole ophthalmology, important MCQs, important questions, important topics. And I believe that more than 70 to 80% of the questions will be from this topics which I am discussing. Okay, now the part 1, first 25 question have been discussed. In the part 2, second 26 to 50 number question discussed. In the part 3, I am discussing from 51 to 70 question, only 20 MCQs, and the rest of the things will be discussed in the part 4. Okay, now if you have no time, you want to jump to the certain topics only, like cornea, retina, uveitis, optics, strabismus. Just search for this questions and you can jump to that part. Okay, so without wasting time, let's start with the question number 51. So the 51 number question, this is the 51 question. Hypotonic maculopathy will not be caused by which of the following? Corneal perforation, cyclodialysis, suprachoroidal hemorrhage, or vitritis. If you know the answer, you can mark it. If you don't know the answer, you cannot mark it. So the answer of this question is suprachoroidal hemorrhage. Okay, because in the corneal perforation, cyclodialysis, in vitritis, there can be the hypotonic maculopathy. Hypotonic maculopathy occurs when the IOP is less than 5 mmHg. And what is the most common cause? Glaucoma, drainage device. Most common cause is glaucoma drainage device. Okay, this is the most common cause. Other causes are like vitritis, corneal perforations, cyclodialysis, vitritis. These are the other causes, and the IOP is less than 5 mm of Hg. Okay, so we have to remember about this hypotonic maculopathy. Okay, now coming to the next question. This is the picture. Okay, fundus of 65-year-old male presented with sudden loss of vision in the right eye, and he is known hypertensive and diabetic. What is the most probable diagnosis? CRAO, CRVO, hypertensive retinopathy, and diabetic retinopathy. Since the patient is both hypertensive and diabetic, you can suspect this type of the picture. But do you think that we have any sudden loss in hypertensive retinopathy? No. In diabetic retinopathy? No. So these two options is ruled out. Do you think that this type of picture is seen in the CRAO? Because CRAO have cherry red spot, so obviously this is also ruled out. So what we are left with? CRVO. This is central retinal vein occlusion, where you have this. What type of appearance is this? Splashed sauce appearance. This is splashed sauce appearance, CRVO. Splashed sauce appearance, CRVO. Okay. Now coming to this is picture of the fundus of the 50-year-old patient with the history of the diabetes and hypertension. What is the diagnosis? This is the picture I have been given, where you can see the tortuosity of the vessels. This is the hemorrhagic area approaching to the fovea, and these are the some of the exudates also. So answer of this question will be what? Patient is having diabetes and patient is having hypertension. 50-year-old, hypertensive retinopathy, diabetic retinopathy, CRVO, BRVO. Can you see this? What happened in the hypertensive retinopathy? In the hypertensive retinopathy, this should be attenuated. The artery should be attenuated. But this is normal. There should be the AV nicking. Means at crossing there should be the AV nicking. But this is normal. In the diabetic retinopathy, you should get the hard exudates, soft exudates along with this hemorrhages. So these are the normal things. So these two options can be ruled out easily. In the CRVO, the hemorrhages will be throughout the retina, not confined to a certain part. So this is because of the occlusion of the certain branch of the vessels. So this is the answer is branch retinal vein occlusion. Got it? Coming to this picture, this is the fundus photo of a 30-year-old male. Presents with the gradual progressive in the vision of both eyes, more in the dim light and at night. That means night blindness. His father and two siblings have the same problems, means hereditary problem. Basis. What should be the diagnosis? RP, Stargardt's, best disease, Ills disease. See the photo. This is typical of what? I have already told you. This is the bony spicules, this is the waxy pale disc, and some of the arterial attenuations can be seen. So this is typical of retinitis pigmentosa. So the answer will be no doubt retinitis pigmentosa. It is having the night blindness, it is having the same hereditary basis and the progressive decrease. Can you see this? I have already told you about this flex, pigmented bony spicules, waxy pale disc, attenuated. See, in the advanced disease, the central area is not involved. So even in the advanced disease, the vision is good. This is the atypical retinitis pigmentosa. When the retinitis pigmentosa is associated with the systemic disease, it is called atypical. Examples are Usher syndrome, where there is a sensory neural hearing loss, Kearns-Sayre syndrome, Bardet-Moon-Biddle syndrome, Refsum disease, and Dasson-Kornjuvic syndrome, also known as A-beta lipoproteinemia. Coming to the next question, silent choroid. I have already told you in the part 2 of my series, the silent choroid is a feature of ARMD, age-related macular degeneration, Stargardt's, best disease, cystoid CME. Stargardt's, where you can, in the FA, you cannot see the choroid. Choroid vessels are not seen. Just see here. Can you see the choroidal vessels here? There is a macular pigmentations or pigmental changes which is present here, but you cannot see the choroid here. This is called a silent choroid. This is called the silent choroid, and it is seen in the Stargardt. Now coming to the next question is a picture of the fundus, 60-year-old male with history of the diabetes mellitus, 10 years, the fundus in both eyes shown diabetic retinopathy. So this is diabetic retinopathy. So this picture is of the diabetic retinopathy is already given in the question. Now what does this arrow indicate? What does this arrow indicate? 1 minute. What does this arrow indicate? This arrow indicates, see, this is the yellow lesion, like a lipid deposition, maybe, but the margin is not so, distinct. So if the margin is not so distinct and fluffy lesions, it is usually what? A cotton wool spots, hard exudate, neovascular, obviously cotton wool spot. Okay, this is hard exudate. This is hard exudate. This is soft exudate. Okay. So this has been asked in the examination multiple times previously. Okay. Now coming to the 57 number question. The photo of fundus of a 5-year-old boy presented the decrease in the vision in the left eye. The right eye was normal. The left eye fundus saw the exudation as seen in the photograph. This is the photograph. This is the photograph, and this is the exudation. These are the exudative areas. Okay. You can see this is 5 year. There is a telangiectatic vessels were also seen. What should be the probable diagnosis? See, Coats disease is occurring in the 8-year-old boy, unilateral, can be associated with the exudations and telangiectasia. The whole scenario is coming to the diagnosis of this condition. But let's rule out the other options. Ills disease occurring in the young male. Vitreous hemorrhage is the most common thing. No telangiectatic vessels in the Hill's disease. So this is ruled out. So Hill's disease is ruled out. PHPV, primary hyperplastic persistent vitreous. So these are the blood vessels which is atrophied, fibrosed, but it persists in the adult and it can cause the traction. So obviously this is not the feature of this scenario. Retinal artery microaneurysm in the RAM, retinal artery microaneurysm. There is a vitreous hemorrhage, there is a intraretinal hemorrhage, there is a subretinal hemorrhage, means hemorrhages at every layer. But there is not, this photograph and the scenario is not corroborating with this RM. So our answer is coat stitches. Coming to the coat stitches is that it's an idiopathic telangiectasia, intraretinal subretinal exudation. Male में 75%, female unilateral 95%, mostly 8 years of age boy, and it is NDP related. Leber miliary aneurysm is an early part of this. What is the sign? Decreased visual acuity, there will be the strabismus, and then there will be the leukocoria. This is the different stages. This is the leukocoria you can see. This is the telangiectatic vessels you can see here. This is the exudation. These are the aneurysmal dilatations and telangiectasia. These are the gliotic seasoning, and this area is the late phase. Okay. Now the sealed classification is the latest classification. Sealed classification is the latest classification of the corridor. What is this picture? What is this picture? This picture is PHPV. See, this is the persistent hyperplastic primary vitreous. What is this picture? This picture is, you can see this vitreous hemorrhage. This picture is retinal artery macroaneurysm, RAM. Retinal artery macroaneurysm. And what is this? This is the OCT of RAM. OCT of RAM. So these are the photos of this that can be asked in examination for you. If you remember, it will be beneficial for you. Coming to the 858 number question is saying that a 30-year-old male presented sudden diminution of the vision in the left eye. Sudden diminution of the vision in the left eye. The fluorescent angiography revealed a picture shown here. Okay, revealed a picture shown here. A diagnosis of the central serous retinopathy is made, means this is the CSC. So this is the CSC, where you can see there is a serous fluid accumulating between the neurosensitive retina and the RPE. The OCT image is shown. Which layer is indicated by the arrow? This layer is what? Obviously this layer is RPE, and this RPE is separated from this. This RPE is separated from this. So the answer for this question is RPE. Now you have to remember this normal OCT also. You can see here. You can see what is this? This is, where is the RPE? This is the RPE. This is the RPE. Where is the photoreceptor? This layer is the photoreceptor. This is ellipsoidal zone. So you just take the screenshot and remember all these things. That is useful. Basically you need to remember the RPE only. Now what is the 59 number question telling you? A diabetic patient complains of the decrease in the vision about 7 weeks post cataract surgery. Post cataract surgery के बाद there is a decrease in the vision. Given below is the OCT. This is the OCT. This is the OCT. What should be the answer? What is the diagnosis? I have already given you the picture, shown you the picture in the previous parts of my discussion, that this is the loculated serous fluid in the cyst. This is the cystic fluid loculation. Obviously this indicate what? CME. This is central macular edema. So the answer is cystoid macular edema. The answer is cystoid macular edema. And if it occurring after the cataract surgery, this is also known as the Irvine gas syndrome. This is called the Irving-Gass syndrome. Now coming to this 60. A patient with a history of the blunt trauma, if there is a trauma to the eye, decrease in the vision in the right eye decreased vision. The OCT, this is the OCT which you can see. So what is the diagnosis? RD, macular break, macular hole, retinal dialysis. Can you see this? Whole thickness, there is a hole. So this is nothing but macular hole. This is the macular hole. So the answer for this question is macular hole. Can you see this? When you see through the indirect ophthalmoscopy, you will find this area, this choroid. There is a hole and you see the choroid. You see the choroid here. And this is that macular hole. This is the macular hole. And what is the test on the slit lamp? On slit lamp, you can do the Watzke Allen test. This is the Watzke Allen test. You can see this very clearly on slit lamp. Question number 61. A high myopic presents should with the sudden loss of the vision in the left eye. There is a sudden loss. Or the loss of the vision preceded by the flashes. From photograph, what is the diagnosis? Can you see this? You can see this. There is a lift off. This area is lifted off. That means it is seeming like the detachment. So what it can be? Exudative retinal detachment, central serous retinopathy, optic nerve or rheumatologist. Obviously it's the retinal detachment. Now the two options. The option number A and option number D. Whether it is exudative RD or whether it is rheumatogenic retinal detachment. Just remember, in high myopic cases, the rheumatogenic retinal detachment is common. However, you can also see there is no exudation can be seen here. So it cannot be exudative retinal detachment. So the answer is rheumatogenic retinal detachment. What is this? You can see there is a fold which is causing the traction. There is a fold of the retina here which is causing the traction of the retina and causing the retinal detachment. So this is nothing but tractional RD. And you can see here, you can see there is a lifting off of the retina and some exudation can be seen here. So this is exudative retinal detachment. Now coming to the 62 number question, a patient who is on the treatment for the rheumatoid arthritis. The patient is on the treatment of the rheumatoid arthritis and complain of the decrease in the vision. The fundus and FFA picture is showing here. The fundus is given here. Okay, you have to see what is the diagnosis. Okay, I have only given you the fundus picture, just make the diagnosis. Purposefully given only fundus picture. Cystoid macular edema, serous retinopathy, bullseye maculopathy, age-related macular degeneration. Whenever you have the rheumatoid arthritis patient, what you are treating with? You are treating with the chloroquine or hydroxychloroquine. Then the toxicity of the hydroxychloroquine or chloroquine in the retina is obviously bullseye maculopathy. So this is nothing but bullseye maculopathy. So remember this. Now when the chloroquine is having the more toxicity compared to the hydroxychloroquine. So this is the bullseye maculopathy. Bullseye maculopathy, this is the advanced stage. When the chloroquine accumulative dose is 300 milligram. 300 milligram. And when the dose of the hydroxychloroquine is 1000 gram, then only the chloroquine toxicity have been suspected. You have to understand that if the patient is on the treatment, you have to rheumatoid arthritis, you have to consult the rheumatologist. The patient should consult the rheumatologist before stopping the drug. And if you suspect this type of toxicity. Coming to 63 number question, snow banking is seen in which of the following? Snow banking is a feature of uveitis, posterior uveitis. No, snow banking is a feature of intermediate uveitis mostly. So what you see? Pars planitis, endophthalmitis, port regis, ill regis. Answer is pars planitis. Can you see here? These are the area. This is the area where you can see the exudates are. This is nothing but snow banking. These are the snowballs. And what we call it? Pars planitis. Now a 30-year-old male has a pain, redness and mild diminution of vision past 3 days. Only 3 days history. Also low backache pain for the past 1 year. There is a low backache pain. On examination, there is a circumcorneal congestion, few keratic precipitates, 2 plus anterior chamber cells, intraocular pressure is normal, the patient is most probably suffering from. The scenario, see, keratic precipitate is present, cells are present, obviously diagnosis क्या होगा? Anterior uveitis, right? Then what is the answer? Most common anterior uveitis association with this low backache, sacroiliitis, rheumatoid ankylosing spondylitis. Ankylosing spondylitis. The patient is suffering from ankylosing spondylitis, and this ankylosing spondylitis fits in which option? ACA, acute ACG, JRA, HLA-B27 or herpetic. This is herpetic. C, HLA-B27 associated anterior uveitis has to be the answer. C, this above MCQ is typical of ankylosing spondylitis. Ocular manifestation is mainly acute. This picture is from the Kansky authentic book. So it affects mainly the male. 90% of them are HLA-27 positive. Spondylar arthritis, acute anterior uveitis is the most common ocular manifestation. And why low back pain? Low back pain is because of this sacroiliitis. So in this patient, you have to ask to go for the X-ray sacroiliac joint. Okay? Now coming to the next question. Bilateral uveitis, skin pigmentation and tinnitus is a feature of Waardenburg, VKH, Alport's and Wegener's. What do you think? It's a sure straight answer. VKH, where you have the eye disease, skin disease and CNS manifestation also. See, VKH is an idiopathic multisystem autoimmune disease where there is a melanocytic containing tissues such as the uvea, ear and meninges, because they occur and this affects mainly Japanese. This is the granulomatous disease, so it's a chronic granulomatous disease. Can you see this photo here? This is mainly the poliosis. This is vitiligo. The eyelashes is white. This is poliosis. Okay. And you can see this sunset glow sign. Sunset glow sign. What Kayanogi Harada disease में sunset glow sign मिलता है. This can also be an important question. Coming to 66. Headlight in fog appearance. Headlight in fog appearance occurs in the feature of which disease? Toxoplasmosis, CMV retinitis, sarcoidosis, tuberculosis. Answer. The answer is very straightforward. It's a toxoplasmosis. Because of severe vitritis, you cannot see the disc easily. And that's why it appears like there is a headlight which is present in the fog. You can see the fog light in head appearance. Now coming to this point. So what is this? What is this? This is nothing but toxoplasma. Headlight in fog appearance. Now the rest of the two things is there. These two things are this is nothing but CMV. This is CMV retinitis. Can you see this? Can you see this hemorrhages, exudations? But there is no vitritis. In CMV, vitritis is minimum. This is called retinitis pizza pie appearance, cottage cheese appearance, or there is a phlebitis. You can see this phlebitis. Can you see this phlebitis? See here, this one, this. Appreciate this. Appreciate this branching pattern. Can you appreciate this? So this is like the frosted branch angiitis. So these are the feature of the CMV retinitis, right? So you have the CMV retinitis also. 67 number question. Come. A 22-year-old man complains of the difficulty in reading newspaper in the left eye and weeks after the gunshot injury in the right eye. There is a gunshot injury in the right eye and there is a problem in the left eye. After weeks. So what should be the answer? If the injury is in the one eye and the problem appears after certain weeks in the other eye, what should be the problem? What should be the diagnosis? Yes, right. It should be sympathetic ophthalmitis, right? Sympathetic ophthalmitis. The injured eye is called exciting eye and the other eye is called sympathizing eye. What is important for the sympathetic ophthalmitis? Sympathetic ophthalmitis is a chronic granulomatous uveitis there is a Dahlen-Fuchs nodule which is present between RP and the Brooks membrane. And remember, this is not the pathognomic of this because it is also present in the VKH syndrome. So what is this? These are the Dahlen-Fuchs nodules. These are the Dahlen-Fuchs nodules. And this is the granuloma of epithelioid cells, Dahlen-Fuchs nodules. Uveal effusion syndrome is associated with all except ciliochoroidal detachment, nano-ophthalmos myopia, structural defects in the sclera. What should be the answer? Uveal effusion is obviously occurs after the ciliochoroidal effusion. There is a ciliochoroidal effusion in the uveal effusion syndrome, and this ciliochoroidal effusion causes the ciliochoroidal detachment. So this is the right thing. This occurs when there is a scleral defect or scleral abnormality congenitally, and the eye, this is more frequent in the nano-ophthalmic eye, chota aankh. So obviously I have ruled out this one and this one. So what we are left with? This is the right answer. So idiopathic uveal effusion syndrome is a congenital anomaly of the sclera. It's sometimes divided in three parts: nano-ophthalmic eyes, non-nano-ophthalmic eyes, sclera abnormality, and obviously there are three things. So you can remember all these things. Nothing to read many things, just I am showing you that what is associated. Nano-ophthalmic eyes is associated, hypermetropic is associated, sclera is abnormality is associated, and it is ciliochoroidal effusion. Anisocenia. What is anisocenia? Difference in the size of the pupil, difference in the curvature of the cornea, difference in the axial length, difference in the size of the image of the two eyes. This is an AIMS question. The answer is D. Difference in the size of the image formed by the two eyes. So what is this difference in the size of the pupil? This is called anisocoria. Aspirants usually confuse this anisocenia with this anisocoria. So remember this. Anisocoria is pupil. Anisocenia, where there is an eye. Eye for image and eye for this. Remember. And the last question of this session is oblate shaped cornea is seen in with the rule astigmatis, against the rule astigmatis, oblique astigmatis, post myopic LASIK. You know, we are what the normal cornea is 1 minute. Normal cornea is prolate. Normal cornea is prolate. But after LASIK, there is a flattening, right? There is a flattening. And because of this flattening, it becomes oblate. So the answer for this question is post-myopic LASIK. After LASIK, we do the ablation and there is a flattening of the cornea, and that's why it becomes oblate. Normal cornea is prolate, can be asked. So I hope you like this video. Part 3. Part 4 is of 30 MCQs, a bit lengthy but very important because lots of topics have been discussed in the part 4. So do watch all the parts and crack your exam with excellence. Thank you.